Again, my name is Anu, and I'm a second-year child and adolescent psychiatry fellow at UC Davis. Today, I'm going to talk about how we can improve the learning experience of our psychiatry residents and fellows. An outline of my talk, a little introduction to our clinic, the referral process to the child and adolescent psychiatry behavioral health clinic, aims of the project, the methods, some preliminary results, discussion, and some future considerations. So why do we care? So as you already know, as I've said, I'm a child and adolescent psychiatry fellow, almost done. And I know that I have a hard time getting connected, having patients getting connected to therapists, but patients have a hard time getting connected to psychiatrists. And so there is a national and local shortage of child and adolescent psychiatrists. The shortage of child psychiatrists in California affects our community and the wide UC Davis catchment area that extends broadly into more remote counties in our state. General psychiatrists, particularly those practicing psychiatry in rural communities, are often expected to evaluate and treat children and adolescents. So who sees the child and adolescent population at our clinic? We have our CAP fellows, our third-year adult psychiatry residents, and residents in the combined family and internal medicine programs. All new intakes are supervised by our child and adolescent attendings. So these are common terms for me, but I just wanted to take a minute to just kind of talk about, the differences and the similarities between our fellow, what a resident is and an attending. So we've all finished medical school. So we've been through 4 years of medical school. Then we complete a certain number of years in our preferred specialty. So in our case, it's psychiatry. General psychiatry is 4 years, and that's primarily working with adult patients. Our general psychiatry program at UC Davis, we see child and adolescent patients during their 3rd year for a half-day clinic. And then our CAP fellows have completed 3 to 4 years of adult training in psychiatry, and now are completing their 2 years of child and adolescent psychiatry fellowship. And our attendings have, and then we have our combined programs at UC Davis. So we're really fortunate. We have combined programs here. So what that means is they're doing either a combined program with internal medicine and psychiatry or family medicine and psychiatry. And again, they have a half day a week of child clinic. And then we have our attendings. They've completed all their trainings and they've taken their boards or are board eligible. So how can we refer our patients to CDHC, our clinic? Families can be referred by their PCP, therapists, from the Mind Institute, or even just self-refer. Location is truly not a barrier to established care, and now, as Amy's did such a nice job talking about telemedicine, I think telemedicine is just broadened that scope as well. Anywhere in California, truly, we can see. We see all diagnoses, including ADHD, ASD, depression, anxiety, psychotic disorders, and substance use. For this particular clinic, we do have an exclusion criteria. We don't see the Medi-Cal population at this clinic. So how are patients distributed in our clinic? Currently, new child and adolescent psychiatry patients are assigned to 3rd year and combined residents and child fellows by age. By using age to stratify patient referral, there is no distinct consideration for the case complexity or the diagnosis the patient comes in with. What that means generally is that child fellows might see younger patients in the clinic, whereas residents will see patients older than 9 or 10, and then all of us will see patients up until about 18, and case by case, it depends if we see anyone older than that. So the aims of my project include to examine whether the current referral by patient age to general psychiatrists or CAP fellows affects the overall complexity of the patient panel, to determine whether each training program has adequate diagnostic diversity within their patient panels, and to measure interest in child and adolescent psychiatry as associated with training experiences. I think the overall goal of my project is, I love being a child psychiatrist, so how can we get more child psychiatrists out there, right? So what can we do to better get ourselves out there earlier on, and show that we're a great group of people, and we have great people we can, rely on. And I mean, there's so many here that I, call upon so often. The methods used in my project, we did a qualitative and a quantitative data was collected from 2 sources. I did an anonymous survey to all residents and fellows seeing child psychiatry patients, and also then analyzed patient demographics through the EMR. The analysis focused to characterize patient factors, including the diagnosis, the complexity of the patient, and the medication regimen. Some questions asked in the survey included the complexity of the diagnosis, child fellow versus the adult residents, the age of the patients, the medication regimen of the patient, child fellow versus adult resident, number of medications, and type of medications. And as I read it out loud more and more, we're hoping the gap between the child fellows versus the adult residents shortens, and that gap, the goal is to bring that, close that gap basically. So preliminary results, residents showed continued interest in child and adolescent psychiatry, but there does seem to be room for improvement. So some discussion points: could earlier exposure peak CAP interest? Could a more diverse patient panel peak CAP interest? And I think the future of the program and what we hope to do is allow residents the option to have younger patients or older patients, right? Because sometimes fellows might want to see older patients. Sometimes they're more complex with substance or probation or, the multitude of other things that might be going on. Residents and CAP fellows may benefit from a CAP boot camp at the start of their academic year. Could we start a CAP interest group for the first-year residents, even before they start seeing child patients in their 3rd year? Encourage CAP fellows to have a more active teaching role with the residents. Sometimes it's easier when it's peer-to-peer rather than attending to resident. Early exposure to leadership roles and advocacy. And I think the way to kind of rate, so this would be our rating, is to have regular surveys to see how the residents and CAP fellows are feeling about their experience. Because I know I put this survey out in February, and so that's already past the half year mark of their 3rd year. And so just doing it more often and earlier